Iba na kasi ang panahon ngayon. Pakiramdam mo, naglalakad kang pauwi ng hating gabi at kinakabahan ka. Yun bang kahit anong ingat mo, anytime, pwede kang matiyempuhan ng masasamang loob.
Tuwing lalabas ka ng bahay, ang dami mong iniisip na pwedeng mangyari. Para bang nasa gitna ka ng dilim. At nagdarasal ka na lang na sana may proprotekta sa'yo kung sakasakali.
Ang pandemya ay parang isang iskinita na kailangang daanan. Alam mong may nagtatago sa dilim, pero wala kang nakikita. Puno ka lagi ng pangamba. Pero may liwanag na naghihintay. May proteksyon laban sa COVID-19. May maaasahan kang backup. It's time to vac up. Oras na para magpa-COVID-19 vaccine booster. For backup protection, control and prevention. Para sa mga 5 taong gulang at pataas, eligible na kayo para sa first booster shot kung nakumpleto nyo na ang inyong vaccine primary series. If you are a senior citizen or a frontline health worker who is 18 years old or above and have completed your first booster, you are eligible for a second booster shot ayon sa Philippine Department of Health. Ang COVID-19 vaccine boosters ay nagbibigay ng karagdagang proteksyon na maaaring humina na ang bisa mula ng inyong huling vaccination. Booster shots are effective in helping prevent serious illness, hospitalization, and even death. So, stay up to date with your COVID-19 vaccination. Kasama na dito ang booster shots. Magtanong sa inyong doktor o barangay clinic kung ano ang naaangkop na COVID-19 vaccine at tamang panahon para sa inyo. Sabay-sabay nating lakbayin ang daang patungo sa malusog, malakas at magandang kinabukasan. Protect yourself and your loved ones. Help control and prevent the spread of COVID-19. It's time to back up.
Let us put ourselves in the holy presence of our Lord. Our dearest Heavenly Father, thank you for making all things possible. We are grateful for all the blessings you are pouring upon each one of us, despite the challenges we are all currently facing. Thank you for blessing us today with the wonderful opportunity to meet virtually and learn together in the awesomely exciting webinar. May your blessings of wisdom and guidance be upon us, all through the sharing and impartation of knowledge and skills by our resource speakers, facilitators, and moderators. May all of us learn together, upgrade our competencies, and capacitate us to be the help in the development of our learners' lives and communities in the spirit of your love and generosity. May we now humbly commit every part of this webinar to you as we all bring you the glory, honor, and praises for your kingdom and holy name's sake. All this we pray in the precious name of our Lord and Savior Jesus Christ. Amen.
Through the dreadful darkness, we shall lead the light and lead a path to wisdom. Our will to be our light. To those in pain and suffering, we shall hear a call. With us to care and comfort from that shall above all, to face a brighter future, bound in unity. The Philippine College of Physicians, we shall be hand in hand, building a stronger nation. This
The Philippine College of Physicians, through the Committee on Media Communication and Health Forum, presents its bi-monthly lay forum to promote the advocacies and mission of the college and its component and affiliate societies. An avenue of accurate and up-to-date conversations with the media and the general public, with timely and diverse topics covering vital public health and medical information, straight from the experts. In a platform that is convenient, accessible, and highly engaging. Welcome to the PCP Health Forum.
Good morning, everyone. I am Dr. Guinevere D. Agra, the moderator for today, and I'm the co-chair of the Committee on Media Communications of the Philippine College of Physicians. This is a joint activity of the Philippine College of Physicians and the Philippine College of Chest Physicians. As we all know, every November, we celebrate or we observe the World COPD Day across the world. COPD, or chronic obstructive pulmonary disease, is the third leading cause of death worldwide, whereas in the Philippines, it's the seventh leading cause of death. So to start off and to open our session, let's welcome Dr. Imelda Mateo, the Secretary of the Philippine College of Physicians, and the current President of the Philippine College of Chest Physicians.
In behalf of the officers and board members of the Philippine College of Physicians, good morning and welcome to today's Health Forum, which is our way of celebrating the World COPD Day, usually in the third week of November, and for this year with the theme, Your Lungs for Life. COPD is the leading cause of mortality and morbidity worldwide. It affects an estimated 300 million people globally, and it is the third leading cause of death worldwide, with about 3.2 million people dying of COPD annually. In the United States, COPD is second leading cause of reduced disability-adjusted life years, or the DALYs, and in the Philippines, it is still one of the top 10 leading diseases. There are a number of challenges we face in addressing COPD, which may be related to healthcare providers, the patient, the caregiver, and policymakers. For the healthcare-related factors, they may be due to challenges on the diagnosis, misdiagnosis, availability, and utilization of diagnostic tools, knowing the proper treatment and management, knowing the multidimensional approach of treatable traits in severe COPD. For patient-related concerns, the late-seeking behavior, the lower socioeconomic status, the mistrust in the healthcare system, the cost of treatment, behavioral and mental health issues, lack of care coordination, especially comorbids, the limited support and guidance, and the inability to reduce exposure to risk factors, with lack of pulmonary rehab services, medication adherence, lack of healthy eating habits and lack of exercises, poor inhaler technique, lack of motivation, misconception about vaccines. For caregiver-related challenges, they may be due to lack of education,
Recording
health
in
issues,
progress.
job issues, lack of leisure time and depression, and lack of motivation of those giving care to our patients. Other challenges may be policymaker related. So in summarizing the barriers and priority challenges, it will include diagnosis or misdiagnosis, the availability and use of diagnostic tools, identifying the important risk factors both for smokers and non-smokers, and the proper pharmacologic treatment or management. There should also be a multi-dimensional approach of treatable traits in severe stable COPD. So what can we healthcare providers do? We can support patients in their efforts to self-manage COPD by encouraging smoking cessation and healthy lifestyle behaviors. We can provide routine patient monitoring, including spirometry, to identify and address any change in symptoms, manage the risk of acute exacerbations, and assess ongoing treatment goals. We can also promote medication adherence by demonstrating and training on correct inhaler technique. So it is so timely that we chose the topic on COPD for today's health forum to bring awareness on the disease with our expert resource person highlighting the important aspects of chronic obstructive pulmonary disease or COPD. Let me take this opportunity to thank our guest speaker, Dr. Rhea Ancelis, and our moderator, Dr. Gwen D. Agra, for sharing their time and expertise. Let us all enjoy listening while we learn about COPD. Thank you very much, and God bless everyone.
Good morning again. So for today's webinar, we will ask our speaker to deliver her lecture, and then later on we will have a Q&A session. Kindly type in your questions in the Q&A box or the chat box if you are in the comment portion if you are a viewer on Facebook. Then we will collate all your questions, and then later we will have a nice discussion after the lecture. But for now, allow me to introduce to you our speaker first. She is Dr. Rhea Ancelis, Doctor of Medicine from the Far Eastern University. She had her residency training in internal medicine at the Western Visayas Medical Center, fellowship training in pulmonary and critical care medicine at the Philippine Heart Center. She had subsequent clinical research fellowship in pulmonary rehab at the Philippine Heart Center. And she is currently the pulmonary rehab administrator at Medical City Iloilo and the head of the Regional Lung Care Center at the Western Visayas Medical Center. She's also a board of director of the Philippine College of Physicians, Western Visayas Panay chapter. Let's all welcome Dr. Rhea Ann Celis.
So good morning, everyone. Let me just share my slides. So, as we know, World COPD Day, usually this is being celebrated every third Wednesday of November. So this is widely celebrated worldwide as an annual global initiative run by your Global Initiative for Chronic Obstructive Lung Diseases. So Your Lungs for Life, as the theme would indicate, is the campaign for a lifelong focus on keeping the lungs healthy as an integral part of future health and well-being. So firstly, I have nothing to disclose pertaining this lecture. So the objectives of this topic, so since COPD is has a very wide scope of subject matters, so this lecture would focus to discuss the burden of COPD and its impacts on public health, and as well as to focus on the contributing factors on COPD, and as well as give some emphasis on some updates from GOLD 2023, and as well as to call for action for COPD in the health community. So let's first define chronic obstructive pulmonary disease. So this is described as a heterogeneous lung condition that is characterized by your chronic respiratory symptoms. Your cardinal symptoms would be dyspnea, cough, sputum production, and exacerbations. So there will also be abnormalities in the airways, which pertains with your bronchitis and bronchiolitis, as well as your alveoli, which would relate with your emphysema. So this airflow obstruction is often progressive and described to be persistent. So with the prevalence of COPD, so the burden of obstructive lung disease reported an overall prevalence of 11.8% in men and 8.5% in women. And it is estimated of a global prevalence of 10.3%. So several systematic reviews and meta-analysis with this provides the prevalence of COPD to be higher among smokers and those who are more than 40 years old, and particularly in men. So in Philippine data, so I found one interesting study. This is done by Delor et al. In 2011 on the burden of obstructive lung disease in the rural setting. So they recruited about 11,188 individuals of non-hospitalized men or women aging 40 years or older, and they recruited a multi-stage random sampling procedures. So these participants had completed questionnaires on respiratory symptoms and they were investigated on exposures to potential risk factors for COPD. So a spirometry was done according to the ATS criteria. So about 722 had acceptable post-bronchodilator studies, and they have found that about 20.8% had belonged to gold 1 and higher. And this is noted that this is greater in men compared with women, and has noted to be increased between the ages of 40 and 70. So with mortality, it is unfortunate that COPD is underdiagnosed and underrecognized, that this would reduce the accuracy of your mortality data. So there would be a death rate of about 4.72%, and there would be an estimate of 3 million deaths annually. And by 2060, it is projected that there would be 5.4 million annual deaths from COPD and its related conditions. In terms of economic burden, so the most well-studied countries, of course, would be the more developed countries, Europe and the US. So in Europe, COPD accounts for about 56% of its cost of the respiratory disease. In the US, it projected about 800 billion or 40 billion per year. In low, middle-income countries, both direct and indirect costs may be substantial, and it is noted that there is poor availability and largely unaffordable inhaled medicines. So this indirect cost may pose as a serious threat to the economy. So COPD is an increasing contributor to the disability and mortality around the world. As of 2013, it is ranked as the 5th leading cause of disability adjusted life year. So as with the causes and the risk factors, as this is well emphasized with the new GOLD 2023, so they coined in the term GetOmics. So GetOmics, as recently been coined, illustrates the dynamic series of interactions between genetics and environment over time. According to this proposal, the G and E interaction is not only dependent to one another, but also dependent on time, as determined by the age of the individual at which that particular interaction would occur, and a previous history of these G and E interactions that the individual encountered earlier in his or her life. So this slide just shows the several risk factors of COPD, which will be going through as it is a part of our objectives. And we have to consider that, as what I have mentioned, the interplay of such factors would contribute to the development of your COPD. So number 1, tobacco smoking. This is a key environmental risk factor for your COPD. So cigarette smokers has a higher prevalence of respiratory symptoms and lung function abnormalities, and a greater annual decline in your FEV1 and greater COPD mortality rate than your non-smokers. However, it is notable that among these smokers, only fewer than 50% of your heavy smokers would develop COPD, and it is estimated that half of these COPD cases worldwide is attributable to risk factors other than tobacco. So it would simply imply that there are other key players in terms of your risk factors other than tobacco smoking. So with biomass exposure, so in low and middle income countries together contributes about 85% of the total burden of your COPD. And these non-smoking risk factors would usually be attributed to these groups. So it now would contribute about 50% of the global burden of your COPD. So wood and animal dung, crop residues, and coal typically burned in open fires or poorly functioning stoves would lead to high levels of indoor air pollution. So as depicted in this picture, this is more usually found in the rural rural settings. So I have to the second picture below. I have to share that this is part of the anatomy of our an ancestral dirty kitchen. So it's really part of the Filipino culture to have such places, done where your cooking, would take place. So that is one of those issues, and probably a gap for your research in the incoming future in investigating such settings. So your household air pollution is usually associated with an increase of developing of your COPD in the low and middle income countries. So with occupational exposure, this would include your organic and inorganic dust, chemical agents, and fumes. And these are underappreciated risk factors of COPD, especially with individuals whose exposure to inhalation of high doses of pesticides. These individuals has higher incidence of respiratory symptoms and airway obstruction. So an analysis done in a large US population-based National Health and Nutritional Examination Survey has estimated the fraction of COPD attributable to your workplace exposures was 19.2% and 31.1% among never smokers. So with air pollution, so this typically consists of your particulate matter, your ozone, oxides of nitrogen, and heavy metals, and other greenhouse gases. And this is found to be a major worldwide cause of COPD. So this is particularly responsible with concern in your low and middle income countries. So this in never smokers, pollution is the leading known risk factor for COPD. So a study done by Go et al. Found that in low ambient air pollution, exposure of a particulate matter of about 2.5 millimeters and nitric oxide impairs low growth in children, and even this would accelerate lung function decline in adults and increase risk for COPD. So we are all familiar with the genetic aspects of the risk factor of your COPD, and this would be your alpha-1 antitrypsin deficiency with a mutation in your SERPINA1 gene. So all patients diagnosed with COPD should be screened for AATD, especially in areas with high prevalence. So classic pictures would pertain a younger age group of less than 45 years old, and histologically they would have a panlobular emphysema. So a delay in the diagnosis of AATD would lead when this patient group would grow older, they would develop more of a typical centrilobular emphysema. So with the trajectories of lung function, So they had emphasized this graph would particularly relate to our theme, no, your lungs for life. Also, initially, no, at birth, the lung is not fully developed, and it would really mature about 20 to 25 years of age. So it would be even be earlier in female. And this is followed by a not well-defined but relatively short plateau. So at the final phase of mid-lung function, it would typically decline due to physiological aging. So this is the TR1 as depicted here with a green line. This would depict the normal trajectory that can be altered by the process of occurring from gestation, going through birth, childhood, adolescence, and other factors that affect lung growth or processes that can shorten your plateau pace, and even factors that can accelerate aging and hence accelerating your normal rate of lung function decline. So age is often a list of a risk factor for COPD, as there is a physiologic decline in your lung function with age. So in relation to this trajectory, they have proposed terms in describing such individuals group of individuals who would develop COPD. So in early COPD, this is described near the beginning of the process, because COPD would start in life and usually would take a long time to manifest clinically. So this clinical manifestation early would reflect when the initial symptoms and the functional and structural abnormalities are perceived. So with your mild COPD, this term is not synonymous to your COPD, but this describes the severity of your airflow obstruction. So with young COPD, so this is quite straightforward, as this would pertain to the directly relates to the chronological age of the patient. So this would be those who are aged 20 to 50 years old. And this can include patients who had never achieved normal peak lung function in your early adulthood, or those who had a short plateau or early lung function decline. So with your pre-COPD, these individuals are identified, and they have respiratory symptoms or a detectable structural functional abnormalities, even in the absence of your airflow limitation on forced spirometry. So PRISM would describe individuals with a preserved ratio FEV1 FVC of more than 0.7, and after bronchodilation, but would have an impaired FEV1 and FVC of less than 80, or reference after the bronchodilation. So this is, you have to consider that other factors that can contribute with this, check on the smoking status, if that person is a current smoker, other factors such as your high and low BMI. So asthma and airway hyperreactivity may also be a risk factor for development of chronic airflow limitation and COPD. So those adults diagnosed of asthma were found to have 12-fold higher risk of acquiring COPD over time compared with adults without asthma. And lung growth decline in children with asthma found that 11% met the lung function impairment consistent with spirometry classification of an early COPD. So the classic chronic bronchitis, as we have defined it, there is a presence of your cough, expectorated sputum on a regular basis over a defined period, and this cough usually would describe for at least 3 months for over a period of 2 consecutive years, in the absence, of course, of other conditions that can explain these symptoms. So other factors associated with this increasing prevalence would be a male gender, younger age, and greater pack years of smoking. So chronic bronchitis would usually be associated with a cigarette smoke. And this group would describe with more severe airflow obstruction. And also, you have to consider the geographic location of such patients, and if there are increased occupational exposure to other noxious agents. So, a history of your severe childhood respiratory infections has been associated with reduced lung function and increased respiratory symptoms during adulthood. So there is an interaction between your smoking and infant respiratory infections, as well as early life home crowding with lung function. So this is found by age of about 43. And other attributable infections such as your Pseudomonas aeruginosa has been associated with an accelerated FEV1 decline. So, and among other infections, TB is also a risk factor for COPD. So there is a pooled evidence of patients with a prior history of TB, about 21%, as found by a study by Fan et al. So in relation with sex, later data from your developing countries has shown that prevalence of COPD is almost equal in males and females. This would reflect really the changing patterns of the use of your tobacco smoking. There are controversial studies or done by Forman et al. The highest prevalence of COPD in females and in urban settings, but these studies had been quite conflicting with other studies. So in terms of your socioeconomic status, so airflow obstruction and a lower socioeconomic status is associated with an increased risk of developing your COPD. But this is not yet clear whether this pattern of exposure to household and outdoor air pollutants and crowding, and even your poor nutrition, infections, and other factors. So this is still has a very good gap for filling in by research. So among what's new in the contents of the GOLD 2023, they have a proposed taxonomy, which are quite easy to remember, as they are based with emphasis on the exposures that I have mentioned. So firstly, COPDG. So this would pertain to the genetically determined COPD. COPD-D would pertain to your abnormal lung development. Environmental COPD is divided on COPD-C and COPD-P. COPD-C with cigarette smoking and biomass and pollution exposure with your COPD-P, and COPD-I due to infections, COPD-A, particularly those with history of childhood asthma, and COPD of unknown cause, or COPD-U. Of course, we have to consider the clinical indicators for diagnosis of your COPD, and that is to explore on the history if there is presence of dyspnea. If this dyspnea is progressive over time, it worsens with exercise, and if it is persistent, and also on a physical exam, you have noted a recurrent wheeze, the presence of your chronic cough, which is this is typically the first symptom to appear. This may be intermittent and may be unproductive. And if there was a history of recurrent lower respiratory tract infections, and also, as I have reiterated, we have to consider and dig in the risk factors. So, as we can be familiarized with the pathophysiology of COPD, the presence of your airflow obstruction, pertaining with your gas trapping, and as well as presence in severe cases, your presence of your pulmonary gas exchange abnormalities, pulmonary eventual development of your pulmonary hypertension, presence of exacerbations, and a development of multimorbidity. So one of those things we still have to emphasize would be the role of spirometry, as still it is one of those gold standards in the diagnosis of COPD. So we have used it to assess the severity of airflow obstruction, as well. This can be also be used for follow-up assessments, and this can help us guide in therapeutic decisions and what pharmacologic or non-pharmacologic interventions we can offer. And also this can help us identify if there is a rapid decline in disease. So this is one of the newer tools found in your Gold 2023. If you can see, almost not all are the same except for your groupings, your A, B, no, C, D. You used to be a C, D here. Okay. So, of course, we have to start with a spirometric confirmation of the diagnosis, assess the airflow obstruction, then we assess the symptoms or the risk for exacerbations. So with your, they have C and D, they said to have merged this. And they really want to emphasize with your exacerbation history. With your so A and B, almost this is practically the same. You assess your symptoms with your instruments of MMRC and CAT. So this would only really differ if there is presence of more than 2 moderate exacerbations and 1 leading to a hospitalization. So this despite kung lower yung CAT score, this would already be considered as a group E. So in the context of treatment, I will only emphasize with your stable COPD, and I will have it answered with your risk factors as well. So first, number 1 goal is to reduce symptoms and as well as reduce the risk. So this would also correlate with your pharmacological interventions. So as you can see already, this would already differ from our previous guidelines, wherein their recommendation for your group E would be initial combination of your LABA and LAMA, and consider if there is additional ICS if the blood eosinophil is more than 300. So other than that, you can already note that there are they had reduced recommendation for your steroid, except when you add it, use it as an additional medications with your LABA and your LAMA. Of course, with the prescription of your inhalers, you have to address the proper usage in order to in order to give the proper delivery as well as the adherence of the patient. So it is important to educate and train inhaler device, and it also during checkup, it is also checkup and follow-ups, check the ability to use the delivery system correctly and select the appropriate delivery system, and also check the adherence to your inhaled medications. So I just showed you the summary of consensus statements and diagnosis, management of COPD. This is with the initiative of your PCCP and as well as your COPD Council. So just show you the available inhaler and other medications for COPD in the Philippines. But I will not go on through one by one. So in terms of reducing risk, I will emphasize on the non-pharmacologic treatment of your COPD. So in patient groups, it is particularly essential to recommend your smoking cessation and encourage your physical activity, and as well as advice on giving your vaccinations. For your BNE, it is notable that despite your besides your smoking cessation, pulmonary rehabilitation can also be recommended. So with smoking cessation, this is one of those key interventions for your COPD patients, and this should be provided with your counseling when the patient is attempting to quit. So in every physician, so even in the primary care, should be familiar with the brief tobacco interventions, such as your 5As. You ask the patient's status of smoking, strongly advise the patient to quit, assess the readiness to quit, and even assist the patient in quitting and arrange a proper follow-up. So if such intervention, your brief tobacco intervention is not working, or if the patient has issues on tobacco dependence, so somehow you should consider pharmacotherapies for smoking cessation. So either if you are able to provide intensive counseling and familiar with medications, you may proceed with the prescription, or you may recommend patients smoking cessation clinics, or we have more available lines such as your quit lines. So they may be given your appropriate interventions such as your nicotine replacement products, your varenicline and bupropions, and there are some issues. They have Gold mentioned about e-cigarettes and vaping. However, this is still controversial, as this is particularly not well studied, and as well as there are adverse effects with the use of your vaping and e-cigarettes, and these particular patients who had tried on e-cigarettes would eventually still fall on returning to your cigarette smoking. So with your household and outdoor air pollution, advice of reduction requires a combination public policy and local and national resources, as well as cultural changes and protective steps for the individual patients. So you can advise if it's unavoidable, especially in rural health settings, it is unavoidable. You can advise patients to open the windows, have an efficient ventilation, open your electric fans, and even you can recommend non-polluting cooking stoves. So in terms of genetics, the antitrypsin augmentation therapy is an approach to minimize the development and progression of your lung disease. So there are studies that suggest that there is reduction of spirometric progression in treated versus non-treated patients. And this is more suitable or never or ex-smokers with an FEV1 of 35 to 60% predicted. So another pharmacologic intervention would be your pulmonary rehabilitation. So this is a comprehensive intervention based on a thorough assessment and patient-tailored therapies that is not limited to your exercise training, education, self-management interventions, which are aimed to aims behavior change. And this is designed to improve your physical and psychological conditions in promoting a long-term adherence to health and enhancing behaviors. So it has been shown to be effective therapeutic strategy to improve your shortness of breath, health status, and health-related quality of life. And maybe even evidences are strong in your moderate to severe disease. However, particularly in our setting, barriers for this intervention still needs to be addressed. So in the last objective of this topic, this is to take action for COPD in the health community rather. So number one, we have to acknowledge the burden of COPD. I think we have already done that, or even the few years this had been already. This is a problem that already has been facing us, and also we have to think on the social and economical implications. And of course, there it takes steps. Although we are in this at this stage, we recognize the health and economic returns, invest in cost-effective interventions, and radically reduce your exposures of risk factors. And this is in line with your WHO and of course your framework on tobacco control. So we have to invest in quality COPD services and have a multidisciplinary primary care, which must be feasible and affordable to deliver a comprehensive COPD prevention and care services, especially in our settings. And of course, more research is encouraged in order to explore this very interesting disease. So I have shown pictures, the initiatives and the steps that the Philippine College of Chest Physicians has done to fill in the gaps. So number one, they made a local statements and guidelines in approaching COPD. So this is already existing, can be found at the web page. Although this can, of course, this can still be refined in the incoming years, and as well as educational materials to help our COPD patients. So I agree with Dr. Mateo in terms of policy and the help of our government. The COPD care should be eventually be developed in our local setting, considering the emergence of our universal healthcare. So I think these are one of the chronic diseases that should be addressed. So in establishing your and implementation, so as I have mentioned, national and respiratory strategies to support the public health intervention and health service transformation in order to make these services readily available for all. So thank you, and that would conclude my lecture.
Thank you so much, Dr. Rhea Ann Celis. You have extensively discussed mula sa pathophysiology, risk factors, treatment, and then our healthcare policies. So there are just a few questions. First off, you mentioned the risk factors like smoking, biomass fuel, air pollution, and genetics. I think genetics is the one that's non-modifiable. Is alpha-1 antitrypsin deficiency documented in the Philippines, in Filipinos? And do we have available testing locally?
I think there are available tests for this. Way back in the fellowship, I think in a private hospital, particularly in I think in St. Luke's, we have managed to request such tests. In terms of this disease being documented, I tried on looking for literatures, but I cannot give data regarding the occurrence of of alpha-1 antitrypsin deficiency here in our local setting. But it can be a good development for research, as we can maybe probably the gaps, especially here in the province, it is not readily available. So these are one of our drawbacks in requesting it, as we have to send it to Manila.
Yeah. Well, I think with the data that will be coming in from the CPAS study, we will have robust data about the prevalence and the extent of COPD burden in the Philippines. Then maybe we can also eventually request for some revisions in health policy and make the test available, and we can document further all of these. So there's another question. Mas mataas po ba ang risk ng lung cancer if a patient has COPD?
Yes, there are studies that shows it, because practically COPD and lung cancer has one common risk factor, and that is your cigarette smoking. So there is a high chance of getting lung cancer. Even these two entities can coexist. No, in you have COPD, lung cancer. So either way, because it is really because of your existing risk factors.
Okay, another question about risk factors. Is TB a risk factor for COPD? And can it cause irreversible airflow obstruction? I think you mentioned a little bit on that earlier. So maybe you can just re-emphasize.
Yes, TB can cause, especially, this is more relevant here in the Philippines. Actually, somebody also asked me the same question. If if COPD can cause TB, they asked me that, but it's the other way around. So an infection, or any infection for that matter, can eventually cause your COPD. This is maybe due to their destruction during the destruction process, during the process of your infection, or it was not some cases it was not well managed. No, the TB the treatment failed. The patient refused compliance to use TB meds, so eventually end up with your a sequela of your COPD.
Yeah, some of them may also manifest with bronchiectasis, which may also be considered as a form of irreversible airflow limitation. Okay, another question. Is there an objective way or scoring that we can utilize to determine if patients with COPD with the usual manifestation of chronic cough, if they should be started with antibiotics, especially for elderly patients who do not typically present with fever when having an ongoing infection, such as pneumonia. Thank you.
So there are studies that I have read, I think in the European group, the CRP, they have used this parameter in when you CRP would reflect there's presence of inflammation. So if these are elevated, the patient has this. You have to correlate clinically. The patient has a viscid mucus. The patient has uncontrolled symptoms. So you might as well consider, with the help of this test, you might as well give antibiotics.
Okay. CRP is a blood test, no? It's an inflammatory marker. Or procalcitonin maybe also because it's elevated in bacterial infections. Our patients may also be prone to develop viral infections, which do not necessarily need antibiotics. Okay, you showed us the COPD handbook, no? Handbook for patients and also the locally formulated guidelines. Where can they get that? Where can people have access to the guideline and the handbook for COPD patients?
It is readily can be accessed through our PCCP website. I will try to post the links, but this was made in order to help not only the patient, but also the primary care physicians and other colleagues.
Yes, so I hope you can get hold of that, especially for those who are caring for relatives who have COPD. That will be a big help also. Are there any other questions? Last call. Okay, I know that you are a big advocate of pulmonary rehab. How difficult is it to set up a program? Because I know that there are still a lot of hospitals who do not offer that. I think with the advent of telerehab, maybe they can also sort of have just a minimal setup, but at least encourage the patients to move around. What are your suggestions for those who have been wanting to set up but have been facing barriers and difficulties?
Actually, these barriers, no, is really this is not common in the Philippines, even in Europe and even in the United States. Acknowledge these barriers, such as the patient is far away from the rehab site, and sometimes some groups who need this, especially among those with have a lower socioeconomic status, cannot afford. No, so you have to tailor fit the program. So there are literatures that have suggested that especially in telerehab can shorten the program to at least 4 weeks. So the usual for a rehab program would be at least 6 weeks. No, can extend up to 12. But in terms of setting up your rehab, you have to start with simple in terms of equipment, no, and in terms of tests, and as well as there should be, of course, it must be placed in an area where emergency access can be given. So it would really take a lot of effort. It's not individual. No, it would also involve the whole medical community, especially in acknowledging such intervention are important for this not only in COPD but other groups of patients that have deconditioning. So it would it's not particularly a suggestion, but eventually maybe in the Philippine setting, once that centers can able to establish such rehab services, number one, it would be easy for the patient to go to the nearest center, No, so that this center would offer a rehab, and of course in other regions in the Philippines, no, so there is no access. It's a quite there is inequity, no, in delivering such care. So really, it would take a lot of effort in establishing this, but the your gratification in giving these services to this group of patients, no, who are experiencing this chronic limitations and dyspnea, the gratification is quite high.
Okay. Another question on rehab. Can exercise delay onset of full-blown COPD in pre-COPD patients? If it can, by how many percent? O medyo mahirap sagutin yan.
Yes,
What type
yes.
what type of exercises are advised?
But this is quite valid, and it's quite interesting if you do a research on this, no. So in such patients, no, so of course still, no, even in your COPD, physical activity is still recommended for such groups, no. So with terms of rehab, no, so if there is it would really depend on the goals I have mentioned, no, the goals that this patient would want, no. So would this patient if this patient is an athlete, no, so would he want to return or be fully functional? So if it would be quite different from a patient who just would want to function at work, at least do at least the maximum effort that he can deliver, or maybe in patients who just stays at home, who just want to enjoy playing golf, no, low resistance activity. So it would really depend, no, sa goals of your patient. But it is I have not seen yet, no, of literatures as of now, no, on the pre-COPD groups, but it would be an interesting, no, ground for research.
Okay. Maybe sa mga institutions without rehab facility, we can give access to some videos. Baka yan ang next project ng COPD and Rehab Council, no, to provide some links to videos that the patients can follow, especially upper arm exercises and breathing exercises, maybe. Okay, next question. COVID is relatively new disease that can result to pulmonary fibrosis. Can this eventually result to COPD or cause or trigger the progression of COPD?
Okay, so we have to take in consideration that COVID is an infection. So in the long term, it's possible, no? So with the picture of your PFTs, that's why these are one of those tests that we can request and monitor on the patient. Also for such development, especially if this patient has also other exposures or risk factors into developing COPD. So it's still possible that post-COVID can eventually, in the long term, considering the other risk factors, can develop into COPD.
Okay, I think we have run out of questions and we're running out of time. So we would like to thank again Dr. Rhea Ancelis for enlightening us about the essential information about COPD. We hope that we can do this again next year or in the following months so that we can discuss more about this, one of the top 10 burdens of the Filipinos. Thank you so much, Dr. Celis. And before we end, I would like to just give some announcements. First off, congratulations to the ORGCOM of the Central Luzon Chapter PCP Mid-Year Convention for a successful run. They dared enough to do face-to-face, and it was really a rewarding experience for those who attended. And our annual convention is coming up in 2023. That's how early everybody prepares for our convention. So we really appreciate the board members and the organizing committee for doing that. So pre-Congress, January 28, 2023, it's a hybrid setup, internist guide to comprehensive nutrition care. I believe COPD patients also deserve a good nutrition care. And then May 7, 2023 onwards, that will be our PCP annual convention. We will be celebrating 70th year of existence of the Philippine College of Physicians. So I hope you can also extend the invitation to your chapter, Dr. Celis. So just to close this session, I would like to call on Dr. Alex Hunya, a regent of the Visayas region of the Philippine College of Physicians.
Hi, good morning. So thank you very much to the Committee on Media Communications for another successful event held this morning. So we learned a lot because COPD, as mentioned earlier, is one of the leading causes of mortality, not just in the Philippines, but worldwide. And I learned a lot about how to identify and manage COPD patients, especially since I'm a cardiologist and usually deal with COPD together with my partner, pulmonologist, a friend. So, and I'd like to thank Dr. Celis and Dr. D. Agra for this very enlightening activity. And on behalf of the board of directors, I'd like to echo again the invitation to our annual convention on May 7 to 10 at the PICC, and also please join us for the pre-convention events, which will start on January 28th. So thank you very much and have a good day, everyone.
The Philippine College of Physicians, through the Committee on Media Communication and Health Forum, wishes to thank its media partners, social media followers, and participants. See you again next time, here on the PCP Health Forum.
Recording stopped.